All right, we have now covered normal anatomy and physiology of the pelvis. Now it's time to get into the uterine and ovarian pathology. So this includes the uterus, the ovaries, and the endometrium is what we're going to be talking about first, guys. So let's go over some definitions. The definitions that I really want to hit here, you guys may have heard them, but we're just going to do a little refresher. Amenorrhea, this means an absence of menstruation. Dysmenorrhea, this is painful menstrual cramps. Menorrhagia is heavy or prolonged menstrual bleeding. Hypomenorrhea is abnormally light menstrual bleeding. Hirsutism is excessive hair growth in women. So these are where you see that they're needing to shave every day. They have, the lady with the beard or whatever it may be. Hyperemesis, this is severe form of nausea and vomiting and usually happens during pregnancy. And then getting into our pregnancy definitions. Ready? So we have parity. So this is the number of times that a woman has given birth to a live or stillborn infant at 20 weeks of gestation or beyond. So she is 20 weeks and 1 day. This would be considered in that parity. Even if the baby is stillborn at 21 weeks or 20 weeks, 4 days, whatever it may be, it would still count towards her parity number. Then we have nulliparity, which means she's never given birth to a live infant. Multiparity, she's given birth to 2 or more children. And then curettage. So if you've ever heard of a dilation and curettage, that's what it's referring to. So dilation is the dilation of the cervix, and then curettage is scraping of the body cavity with an instrument. So if they're having an endometrial curettage, they're scraping the lining of the endometrium. Then we have our sonographic terms that we're going to use to describe things when we're talking about masses. These probably sound all a lot like things you have heard before, but I just want to keep in mind as we're going through these. So the overall composition, this is going to be your heterogeneous, your homogeneous, your hyperechoic, hypoechoic, complex. So complex is going to have some cystic aspects, some solid aspects. Echogenic, that's going to be your bright. Anechoic is going to be your completely black, sonolucent. Going back through these again, I just want to, we hit on anechoic, echogenic, and complex just real quickly, but if you guys haven't heard hypoechoic, it means darker than surrounding. So if we're saying something has hypoechoic, then it needs to be hypoechoic in relation to something else, darker in relation to something else. Same thing with hyperechoic. So this means it's going to be brighter in relation to something else. You have homogeneous or homogeneous. That is where it is all one consistent, even layer. And then heterogeneous or heterogeneous is where it's stacked on top of each other. Like if you were to have a glass and you put sand in it, and then you put water in it, and then you put oil on top of it, those would create 3 separate echotextures, 3 different, very obvious areas. So then we have our internal characteristics. So if we have a mass, we're talking about what does it look like inside of it. So unilocular means it's, just one set loculation of fluid, one collection of fluid, okay? Multilocular is where we're going to have a mass, and then within that mass we're going to have loculations or skin attachments within it. So it's going to look kind of like if you were to blow bubbles and put them into a thing, you may have 8 or 10 bubbles in this pile. That would be your multilocular. The pile is the fluid collection, and then within that fluid collection you have all of those smaller bubbles. Then we have fluid. So this is going to give us that anechoic, sonolucent appearance, right? Completely black. Then we have a mural nodule. So these hang out on the outside, and they're going to be a part that is bumped out or echogenic within that mass. And then, of course, internal debris. If you see something floating in there, that would be debris with inside of it. So our wall definition, we can either have a thick wall, we can have a thin wall, we can have a smooth or irregular border, meaning that it's kind of speculated, right? Well-defined or ill-defined. Can you see that wall clearly, or are you kind of squinting to see it? If you're squinting to see it, that would be considered an ill-defined border. Then finally, we're going to emphasize the Doppler characteristics, especially once we get into the ovaries. So, or masses within a structure, right? Does it have blood flow? And so the first one is avascular. With that prefix of A, it means no vascular flow whatsoever. Then you have hypervascular. That prefix of hyper means it's increased vascularity. You're getting a ton of blood flow in there. Hypo, complete opposite. That would be low. Hypovascular means there's very little blood flow. High resistance. So high resistance means that it is hitting a wall. And so when I talk about high resistance, I want you guys just to think of, let me see if I can't kind of draw it out here for you. So if I have a waveform, oh, it's not going to let me draw. Here we go. So if I have a waveform, and it is just phasic, right? And then if I were to have a high resistive waveform, at the baseline, it would come up, and as it's going down, it would hit a wall and then come back. This would be your high resistive waveform. Now, in the same token, if I have a low resistive waveform, when it goes up, it is going to slowly drop down. It's not hitting a wall, and whatever it's going towards is asking for a ton of blood. And then going forward, it would stay above that baseline. So low resistive, we have everything above the baseline, right? Everything is staying above that baseline. There's no sharp downstroke there. For a high resistive, we're going to go up and we're going to almost hit a wall, and it's going to go below the baseline and then come back up. This would be your high resistive waveform. And then for your phasic, it is just moving with respirations here, okay? There's no real pulsatility to it. It can even be, you know, this would be considered phasic here, right? Because if I were to take a breath and it changed, that would be the phasicity or the change of it due to that breath. All right, so taking a look at the pathology of the cervix first. And so remember, the cervix is going to be, if you have your uterus here, right, you have your fundus, you have your cornua, you have your body, you have that lower uterine segment, and then you have this cervix here. We're going to be focusing on only pathologies that hang out in this cervix. The first one we're going to talk about is carcinoma. And you guys can see this mass right here within that cervix. That hypoechoic, very irregular margin there. You may see some fluid within the endometrium, but you may not. So we're looking right here at this mass, and it actually looks like it may be coming. Well, I mean, I guess this would be extremely ill-defined, right? Because we can't see a defined border there. I would even use color to kind of emphasize this mass a little bit more. Is it this mass here, or is it kind of protruding into the cervix throughout that whole thing? That would need further investigation. But so carcinoma of the cervix is an epithelial neoplasm. It is the third most common gynecological malignancy in the United States. So it is very common, and risk factors really are HPV or human papillomavirus, which is a sexually transmitted disease, early sexual activity. So, you know, the sooner you're having intercourse, the higher your risk for cervical carcinoma is. Multiple sex partners. So if you have more than one sex partner, with every sex partner, you are increasing your risk for cervical carcinoma. smoking, and then oral contraceptives. So this is not saying all contraceptive, guys, it's saying oral contraceptives. So just make sure that you're paying attention to that. If it states something about an IUD, that wouldn't increase your risk for cervical carcinoma, because it is not the oral contraceptives which use estrogen and progesterone. Okay, so we talked about that when we talked about physiology, right? Clinical findings. So when our patients come to us, they're probably going to be coming in for the doctor may have felt a papillary mass on the cervix during an exam, or they're having postcoital bleeding. So every time they have intercourse, they're bleeding after intercourse, or they're having bleeding in between their periods, so that intermenstrual bleeding, or just vaginal bleeding and discharge altogether. Now, sometimes it is asymptomatic, and that is why we go and get our Pap exams, because Pap smears can actually detect this a little bit faster than us waiting for a symptom to occur. All right, so then we have Nabothian cysts. Now, these are super, super common. You guys are going to see these all the time. Some people will choose not to annotate them and just comment on them. They won't even measure them. I suggest anytime that you're seeing pathology, you put color on it and you measure it in 2 planes. There are a lot of pathologies that resemble each other. And so if you're seeing it, measure it, document it. But Nabothian cysts are just a regular cyst, simple cyst, right? Thin-walled anechoic structure with posterior enhancement, except these are found in the cervix. So we have a really good picture here. So we have our cervix, then we have our lower uterine segment, we have the body, then we have our cornua, and then we have our fundus. So these do not pass that, into the uterus. They stay right here in the cervical canal. And they are, in fact, thin-walled anechoic structure with posterior enhancing. They are completely asymptomatic. They're generally an incidental finding, and they're generally smaller than a couple centimeters. But so if you see it, mark it. These aren't cancerous. They're just like a cyst in the kidney or the liver, right? We see cysts almost everywhere. Then we have adenomyosis. So adenomyosis is actually a pathology of the uterus. So we have finished our cervix, and we are moving into pathology of the uterus. Okay, so adenomyosis is ectopic endometrial tissue. So what's happening here is that the endometrium is protruding into the muscle or the myometrium of the uterus. We're going to see that the uterus appears larger. We might have some fake thickening or pseudo thickening of the endometrium. It's going to appear like it's larger, but in reality it's just kind of spreading out. So the endometrium is normal, but the endometrial tissue has come into the myometrium. And then straight edge shadowing without a focal mass. And what I mean by that is we have these, we call them curtain blinds, right? When we're scanning through the uterus and we're seeing these curtain blinds, it's usually coming from that adenomyosis inside of the uterus. So some risk factors for this, multiparity. The more deliveries you have, the more trauma, you can say, you put onto the endometrium. So you have a higher risk of that endometrial tissue going awry. Elevated estrogen levels. So if somebody naturally, biologically has higher estrogen levels, or if they are taking estrogen, they might end up with this. And then aggressive curettage. So say you had some polyps or something in the endometrium and the patient went for a curettage or a dilation and curettage after a miscarriage, or a DNC post-abortion. Like, those are going to be things that are going to cause trauma to that endometrium, which would then cause it to grow out. When we're having a patient coming in for this and we're looking for this, really pay attention to their bleeding. So they might not have any symptoms, but then we're probably not going to notice it. But if they're coming in because they're having pelvic pain or cramping, you really want to ask about their menstrual cycles. You know, are they having really heavy menstrual cycles? Are they having a lot of pain in their menstrual cycles, right? That menorrhagia or the dysmenorrhea. So, you know, those history questions are important to ask your patients when you're looking for these uterine pathologies. Leiomyoma, this is everyone's favorite. So this is the most common benign neoplasm. So the most common non-cancer spreading overgrowth of the myometrium, okay? Another name for a leiomyoma is a fibroid. You may see it used interchangeably on a board or something. They have a very wide range of what they can look like. They can be isoechoic, hypoechoic, slightly hyperechoic. They're generally going to be well defined, so it's not going to have an irregular border. And if we have some degeneration or some necrosis happening within it, it may seem complex as well. So you may have, like this one, you know, we have this well-defined mass here, but then inside of this mass, we have this cystic area. So this would be an area of degeneration. Some risk factors for fibroids are going to be African American females, estrogen use, and then age of fertility. And what that's saying is, have you had your first menarche? Have you gone through puberty? If you've gone through puberty, then you are now at an increased risk for fibroids. And then they do grow in size because when we are pregnant, we have more estrogen, and so they will grow in size during pregnancy. And generally, they will cause some irregular bleeding, especially if they're tugging at that tissue. We can also have some infertility issues depending on where that fibroid is, and we're going to talk about their location here in a minute. If they're small and, you know, not in a place that's going to cause bleeding, they can be asymptomatic and you might not even know they exist. So let's talk about placement. All right, so there are about 4 places that fibroids or leiomyomas can hang out in the uterus, and we're going to kind of step through each one of these. So the first one's going to be submucosal, and that's going to be the most inner layer going out, okay? That's going to be these orange ones here. Let me get my pointer. So these orange ones here are going to be your submucosal, meaning they're in the innermost layer. And they're further divided up by how much is into the myometrium or that intramural. So number 1, we have most of it is going to be inside, and only a small portion, less than 50%, is going to be intramural. Then you have where most of it is intramural and a little bit is coming into the endometrium. And then you have an intracavity pedunculated here. So we have a stalk and it is coming into the cavity space within the uterus. Then moving on out, we're going to go intramural. These guys have to be in the intramural contact, okay? So we have our 100% intramural contact here, intramural contact there. They're right sitting inside of this myometrium, and they can be anywhere from here in, right? They're not going to have, you know, subserosal contact. They're going to be in the myometrium. Now, the thing that's unique about 3 is it actually has some contact with the endometrial. So we're going to note that in our documentation, you know, it is intramural with a endometrial contact there. Then we have our subserosal. So we are moving on out. We're going to be looking at these darker blue here. Okay. These guys have contact with that serosal covering here. And it can, again, be mostly intramural with some hanging out in the subserosal space, or it can be mostly hanging out in the subserosal space with just a little bit in the intramural space. And then we can also have a pedunculated where it is attached at the subserosal layer, but then it has a stalk coming out into a free space. And this would be our pedunculated right here, anything that's going to be attached by a stalk outside of the uterus. The other thing that we can really have is this giant purple one here, right? And these guys can get pretty big depending on, how long they've been there, whether there's estrogen use or whatever it may be. So this guy actually has some submucosal contact. It has some serosal contact, and then it has a lot of intramural contact. So we can then note to the doctor that it is submucosal and subserosal and intramural. All right, moving along to some more pathology of the uterus, we have a leiomyosarcoma. So this is a very rare carcinoma of the myometrium, meaning it is cancer of the muscle layer of the uterus, okay? Depending on, what stage of degeneration these are in, they can be very heterogeneous or they can be homogeneous, meaning that they do not have areas of cystic space within inside of them. And they can look very much like a leiomyoma or a fibroid. The key thing here that I want to point out is the blood flow. So if I were to put color on a fibroid, I might get it on the outside. I may get some small bits in the inside, but it's mainly going to stay on that outside. It's being fed in the periphery, not the internal. But with a leiomyosarcoma, we're going to get this increased blood flow throughout the mass. These are going to cause the same kind of symptoms as a leiomyoma. So we're going to have some irregular bleeding, maybe some fullness, or they could be asymptomatic. Moving into pathology of the endometrium. So we have covered of the uterus. Now we're talking about that inner cavity of the uterus, the endometrium. The first one we're going to talk about is Asherman syndrome, which is where we have what we call adhesions or tissue growth, scar tissue from some form of surgical intervention. So this could have been a patient who had a curettage or a DNC, and so they had the lining of their endometrium scraped or burnt out, and now they have these scar tissues or this surgical change. When we are looking at this, you can see this bridge here. This is the endometrium. There's a bridge here that would be an adhesion. So one side of the endometrium has adhered or stuck to the other side. These are really hard to see unless you're seeing, like a shadowing coming from it, or unless the endometrium is filled with fluid. And so sometimes when we're doing these, we will actually fill the endometrium with fluid so that we can see these adhesions a little bit better. And generally this will happen because a woman had some kind of scraping and now she's having infertility issues. She's having a hard time getting pregnant, and they want to make sure that she doesn't have these adhesions post that surgical intervention. Or she's having very, very painful bleeding after she's had some kind of procedure done. Then we have our endometrial carcinoma. So these are going to have kind of the same symptoms, some abnormal bleeding. We might see some weight loss to go along with it. But we're going to have the key thing here is the focal thickening of the endometrium. So you're going to be able to see something that is just one spot in the endometrium where it's nice and thick, and there's going to be some blood flow there because it needs to be fed. Our risk factors for an endometrium carcinoma is going to be estrogen stimulation. You know, are they taking estrogen regularly? Have they ever given birth? If they have not given live birth and they're in that nulliparity, they have an increased risk for endometrial carcinoma. Other factors include obesity and diabetes. All right, and then we have endometritis. So itis, right? That ending there tells us that it's some kind of inflammation. So inflammation of the endometrium. We're going to have a thick, irregular endometrium, and because it's infected, we're going to expect to see some hypervascularity or increased blood flow. Our patient history questions are going to be real key here, because the risk factors for endometriitis, it's not something that you just, you got a cold and now you've got endometriitis. No, there usually was a pre-existing infection like pelvic inflammatory disease, or, you had a placenta that still had some remnants left behind, so that would be considered a postpartum complication, or you had vaginitis, which was an infection within the vaginal canal that has now spread up through the cervix into the endometrium. And then with any infection, we're going to look at labs. If they're having fever and elevated white blood cell, we're going to start thinking infection. All right, then we have a hematometra. So this is a blood pocket within the endometrium. So as the spiral arteries start to slough off in a normal biological process, we talked about this, it would make its way through the lower uterine segment out through the cervix into the vagina, and we would have irregular menses. Well, in this case, something is stopping it from exiting the uterus, and now we have this blood product stuck inside of there. So some risk factors, some causes, I guess you could say, of hematometra would be cervical stenosis. So that cervix has narrowed so much that nothing can get through it. This blood cannot pass through it. An imperforated hymen. So the hymen is a piece of tissue that kind of hangs over, and you can perforate it by riding a bike or riding a horse or using tampons, whatever it may be. It's very easy to perforate, generally happens as we get older and the uterus gets bigger. And the other one would be a vaginal neoplasm. So if we have a growth in the vaginal canal, nothing is going to be able to pass through it, and so that blood product has to stay within the uterus. So some clinical findings. So these are, your patient comes in for an exam because she's 25 and she's never had a period, right? Or she has very, very slight low bleeding occasionally. And she's like, why am I not getting a regular period? Or she's having pelvic pain and they feel some kind of mass hanging out when the doctor goes to do a physical exam. All right, then we have hyperplasia of the endometrium. So this is when the tissue in the endometrium is thickened and growing, right? So it's getting thicker as it goes. Some risk factors for this would be unopposed estrogen. If the patient is receiving hormone therapy, more specifically tamoxifen. If the patient has polycystic ovarian syndrome, they're at an increased risk for endometrial hyperplasia, and then obesity. So this isn't really common in reproductive years, but pre and post menopause, it may cause some abnormal bleeding because that endometrium is still thickening on that hormone replacement therapy. Next, we're going to talk about polyps. So polyps Just like we can get gallbladder polyps, we can get polyps in the endometrium. These are going to be focal areas that are bright within the endometrium, and we are going to see a vascular stalk. So when we're looking at these masses, there will be some kind of blood flow coming out from them. They're, again, really hard to see without that endometrium having fluid in it. But if we're lucky enough to get some fluid or they insert fluid in, we can see them really well. If you can't, you'll notice that we have our endometrium here, right? And then we have this like bright circle there. That would cause me to think polyp. They're pretty common peri or postmenopause. So as a woman is entering menopause or after she has already gone through menopause, meaning she's no longer having a period, we would start looking for these polyps. Abnormal bleeding and infertility are going to be some clinical features of these. And I want to note here, because I remember it being a question on my boards about, a patient being prescribed progesterone after being diagnosed with a polyp. Why isn't she seeing results? Well, the thing is that polyps are unresponsive to progesterone. They're not going to get smaller if you're giving them progesterone. All right, tamoxifen effect. Now remember, I just mentioned that tamoxifen is a hormone replacement therapy. So it actually will block some hormones that we would expect to see. So we're going to, again, see that thickening of the endometrium. It's going to have a complex appearance. And maybe have some abnormal bleeding. Guys, I just want to point out that the last couple that we went through of the endometrium, they all look very similar, right? So if we have hyperplasia, that's going to look a whole lot like a tamoxifen effect. If we have a polyp, and we don't have that fluid in the endometrium, it could also look a whole lot like a tamoxifen event. And the only thing that you can do is describe it. So, describe it as a heterogeneous, complex, thickened endometrium, and then they're probably going to do a scraping and clear it out and see, what is causing that. Is it endometrial tissue? Or is it possibly something more ominous like an endometrial carcinoma? All right, so we're going to go ahead and move on into the ovaries now. So kind of broke this into cystic pathology, solid pathology, and then vascular pathology of the ovaries. So bear with me. I'll try and keep up with where I'm at. If I'm moving into a solid, I think it makes it so much easier to learn all of these if you can break them into, okay, this one's going to appear more cystic, this one's going to appear more solid, and then this one, it has nothing to do with appearance, rather the vascularity of it. So cystadenocarcinoma. This is an epithelial neoplasm. It is a complex mass. We might have some nodules in it, right? Some bump outs, nodularity with it. And we might see some ascites. This is a cancer, so family history is going to play a huge part in risk factors for it. We might see some weight gain from those cysts in there. We might see some pain, or they have felt a mass on a palpable exam. Cystic teratoma, so you might hear this also called a dermoid cyst. and it gives the classical tip of the iceberg appearance. So what happens is so this is a dermoid right here, and you guys can see we have this super bright tip of the iceberg, and then we get nothing posterior to it. Okay, dermoid cysts generally get kind of gassed out like this because they have fat in them, they have hair in them, they can have skin, they can have teeth. They're really quite ugly. They're formed out of germ cells, so they can have a variety of different characteristics to them. The nice thing is that it is benign, so it's not a cancerous causing mass. And it is the most common benign ovarian tumor. So if you're trying to see an ovary and you're hitting this tip of the iceberg, right, this really bright spot, and then it's kind of shadowed out, you might have to differentiate, is this bile gas or is this a teratoma and coming from a different angle? Cystadenoma or a mucinous cystadenoma is a anechoic mass. It may have some debris inside of it. It is an epithelial neoplasm, and clinical findings are irregular menses, pain, and a mass. This is not a picture of a cystadenoma. This is that teratoma that we were looking at, not a cystadenoma. They are going to be anechoic, looking like a cyst. Then we have polycystic ovarian syndrome. So these are just a bunch of cysts in the peripheral. They're really small because they're generally caused by a luteinizing hormone or a follicle stimulating hormone imbalance, which means these follicles are being stimulated, but they're not actually ovulating. So we have what's called anovulation, without ovulation. And you can see here, so this would be a normal ovary, okay? Yes, there are cysts on the outer section, right? But the key fact here is that these are coming into the center. When we're looking at someone who has true polycystic ovarian syndrome, we're not going to see anything in the center. They're going to stick, all of those chocolate chip cookies are going to stick on the outside. Here's another example here. We have nothing going on in the middle. So this would be a classic polycystic ovarian. These females who present with polycystic ovarian syndrome, or POS, generally have a lack of a increase of hair on their face. So they have very thick hair all over their face. They're struggling with infertility because they're not ovulating. They're getting all of these cysts, but they're not ovulating, and then they're probably having a very hard time losing weight. They're also probably going to have irregular periods, times where they may go 6 months without having a period, and then they'll have a period, and then they'll go again infrequent, that oligo, meaning very infrequent periods. All right, then we have a serous cystadenoma. This is the second most common benign ovarian tumor. So if you recall, our first was that dermoid cyst. This will be our second most common. Irregular menses, pain, again, bloating or feeling of a mass are going to be our clinical findings, and then our sonographic findings are going to be multilocular cyst. We call them daughter cyst or sister cyst within the ovary. And so we can see here we have our ovary here, and then we just have a ton of these cysts all over, very, very tiny cysts all over the place. which is very different than our theca lutein cysts. So these guys have large cysts all over their ovaries, and these are going to be bilaterally. The key finding between the two different types of cysts here is the theca lutein cysts are going to have an elevated of HCG lab. So they might have a positive pregnancy test if they were to have these theca lutein cysts. They're probably also going to be very, very sick, having some excessive vomiting or hyperemesis as they, get these cysts. Then we have our Brenner tumor. The big thing with the Brenner tumor is going to be its correlation with something called Meg syndrome. So Meg syndrome is a pretty rare condition, and what we have is we have fluid in the abdominal cavity and in the pleural space. So we have ascites and we have pleural effusion. That in itself is MEGS. So the presence of fluid in the pleural space and the abdominal cavity is MEGS. And if we're seeing these cysts in the ovaries, that would be more likely to be a Brenner tumor. They're going to have some pelvic pain or pelvic fullness, and you'll have a very hypoechoic, well-defined tumor. These are benign, and they're not going to generally be a cystic hypoechoic, but they might have some posterior enhancement with them. And then we have our ovarian carcinoma. Risk factors are going to be your keys here with ovarian carcinoma. So it's going to be someone who probably has not had a live birth, or has a family history of known breast cancers. They might be infertile, which would contribute to their nulliparty, or they're in late menopause. They're getting ready to have no periods, that sensation of the menstrual period. These masses on the ovaries are very irregular. They look a whole lot like everything else we've been talking about. So the risk factors and then the clinical findings are going to be key. Patients with ovarian carcinomas generally have an elevated CA-125, which is a cancerous marker. And so if they have that CA-125 and you go to look at their ovaries and you see something like this, we're going to be thinking it's ominous. It's probably ovarian carcinoma. Then we have our dysgerminoma. These are really common in childhood. So these are ovarian cancer found in childhood. It is a germ cell cancer. It's usually unilateral, and these patients are going to have that elevated HCG and an elevation of AFP, and so probably some precocious puberty. If you remember when we talked about physiology, precocious period is going to be having breast or pubic hair before the age of 7, and then a period before the age of 10. Now this form of malignant germ cell does spread to the lymphatic system. So if we're finding this, we're probably going to be doing some lymph node biopsies as well. Fibroma. So these are benign. We do have that same association with Meg syndrome, so fluid in the pleural space in the abdominal cavity. They are solid, hypoechoic, generally homogeneous, and when we were talking about something that would set this apart, it's really going to be the shadowing that happens posterior to it. So just like when we have that blind happening. We're going to have it with these fibromas as well. So you can see there's some here, some here, some here, and that's going to set it aside from our Brenner tumor, right? Because our Brenner tumor and our fibroma both have an association with Meg syndrome, except our fibroma is going to have that blind appearance, the shadowing coming out from it. We have a granulosa cell tumor, solid, could be homogeneous, could be heterogeneous. We might have some associated endometrial thickening, and then depending on how much necrosis, depends on, you know, how complex this is going to be. It is really dependent on hormones. So, you know, it may increase in size or decrease in size. Well, not really. It will increase in size with estrogen use. So if somebody's taking estrogen and having some irregular bleeding, that granulosa cell tumor might be your best bet. A thecoma. So these are super hypoechoic masses. They might have some calcifications or some shadowing with them. They are a benign tumor, but they produce estrogen. So if we're having elevated estrogen levels and we're not taking estrogen, a thecoma might be our culprit. All right, so last but not least, we are going to talk about two different vascular pathologies that we need to look out for when it comes to the ovaries. AV fistula, so this is an arterial venous fistula, meaning that the arteriole and the vein have something communicating between them. So when a woman had a malignancy or some kind of pelvic trauma or a surgery, there's a potential that a communication will be created between the artery supply of the uterus and the venous supply of the uterus. And so arterial blood is mixing into the venous supply, or the other way around. These women probably are going to have some kind of like anemia or menorrhagia or something going on with, you know, internal bleeding or blood supply issues, right? And when we put color on, we are going to get that aliasing in the veins because we are having an increased amount of blood flow going into the vein. And then that vein will become super dilated with that extra pressure. The other thing is if we were to put a pulse wave into the arterial flow, we may see some phasicity with it, meaning that that spectral window is going to close and we're going to see, you know, if I have my baseline here, and a normal arterial flow would look something like this, right? But if I have an AV fistula, I might end up getting something like this, where it's completely filled in, that spectral window has been closed, and I'm even getting some flow going this way as well. So I'm only seeing the top peaks here. We've got some venous flow that's coming in behind it, and we have no spectral window. Now, ovarian torsion is going to be really an emergent ultrasound. So when we're not getting blood flow to the ovary, it's going to necrose, it's going to die, and we want to save that ovary as quickly as we can, much like if it was a testicular torsion, right? And so we're going to have those same symptoms: extreme pelvic pain, nausea and vomiting, a pelvic mass, very acute pain, meaning it just started and went from 0 to 100. And then when we go in to look at those ovaries, they're going to be enlarged. We might have some free fluid around them, and then when we put our Doppler in, we're going to have an absence of venous and arterial flow inside of the ovary. Now, a key thing that we have to be super careful for with ovarian torsion, and this is why we need to know our anatomy and physiology. Do you guys remember that the ovary is fed by two arteries? So we have the ovarian artery and the uterine artery that are both feeding that ovary. So checking to make sure that you have adequate blood flow for these exams is going to be critical. And we would expect to see, depending on the menstrual cycle, you know, you might expect to see a lower velocity or a higher velocity, lower resistive waveform. So that is all of our pathology for the ovaries, the uterus, and the cervix. If you guys have any questions, bring them to class and we'll go over them.